discussion, their experiences. And we all know everybody is doing a good cataract surgery, managing with better systems. And practical skills are different and machines are different. So both, if combined, the results come out to be truly friendly for patients. So today we're going to start with Abhishek Dhaga, who's going to talk about his experiences with this system of surgeon's perspective, how we look into all these newer things. Rohit is not here today, I think. Is going to come? Dr. Rohit Om Prakash might join me after some times, and in the meantime, Dr. Grover is free. He can come and sit with me, sir. Abhishek.
Thank you so much, sir. A very good afternoon to everybody here, and we thank the local organizing committee, AIOC, and NIDEC for arranging this symposium. I would be talking about my perspective on what are the advantages so-called advanced phaco machines offer, apart from burning a hole in your pocket. Essentially, we want to value add. Whenever we move on to a better technology or when we want to move on to a better system, we would want to essentially give patients the better outcomes with the best value add possible. I did a quick search, and this I did 3 years ago, when I wanted to look at advantages of newer phacoemulsification machines. In 0.5 seconds, I had 2 lakh plus results. So I kind of Googled it to an advanced phacoemulsification, and I got some more results and advantages. So there are more than 2 lakh documented advantages of this. But essentially the drawback of older options was that, sometimes we would not be very consistent. We would have a variable anterior chamber. We would have a variable phaco delivery. We would have the potential of thermal injury to the cornea, and sometimes we would not be able to get that correct phaco power, or the modulation would not be to suit our needs. All of us can do phaco in NS2, 2, 3 odd cataracts very easily, but you can't. I don't know practitioners here. So the patient expects good results. You can't go back and tell the patient you had a harder cataract, you had a leathery cataract, you had a posterior polar cataract, you had a complicated injury. The patients. I don't know. So the two of you have more experience here. The last OT, the patient stood up from the table and said, "Ki mujhe dikh nahi raha abhi." I was flabbergasted. Just off the table and said, "Ki I can't see. Why am I not seeing immediately?" So you would want
But I think there is a lot of misconception spread by us only.
Yes,
sometimes we talk to the patient in a manner, we are going to give you everything possible in this world, which is not true.
It is not.
I think
myths have created around cataract surgery, legends.
I was speechless. I didn't know what to say.
It happens quite often.
Yeah, very often. Yeah.
Thank God.
Maybe in your premium practice, but yes, for
most
me
people
it was
experience
first,
this.
Yeah, so anyway, we would want something which is more consistent, which we can, and not just the phaco machine, we would want the entire system. We would want not just the machine to do the cataract surgery, we would want the complete package, which gives us a better solution to be offered to every kind of patient. And, such cataracts where we don't know what we'll be doing next, if the machine, at least something is consistent. Your surgeon is consistent, the machine is consistent, and your UPS is consistent. So you would want the phaco machine to work for you all the time, because the patient, such a cataract, the patient would want such a result, and I think to a very large extent we work on trying to make systems safe. In such cases, the reason I'm showing you these cases, we get these patients only. The patients who have earlier cataracts would go to a more premium practice. To our practice, patients come with this and they want the same results. So you would want a system in which you can modulate the phaco energy. You could efficiently use it without causing corneal wound damage. You would essentially want an atraumatic surgery. You would want the patient to have a good recovery. Such brown leathery cataracts which we see all the time with us, you would want that the phaco machine gives you this kind of a surgery every time. So it is not just that I have to sort out videos and choose these. Every surgery, every case, every such case, we would want such a result. So the other thing which I really sometimes talk about, and I would take an extra minute, I'm showing, the reason I put these videos is not, you can notice that these are not the same patients. These are different videos. but you would see that the surgery would go on in the exact same manner. Wouldn't we all want this? Wouldn't we want that any type of patient, any type of cataract, we get the same result irrespective of what the situation demands? So, today in phacoemulsification platforms, you also have the advantage of getting a dual pump. You could actually look at a pump which is not just peristaltic but also a venturi pump which can give you, a venturi driven pump gives you a better performance, it gives you more followability, it gives you, for surgeons who do a primary chop or who does such cases with, and would want a better machine, a better car. Sometimes some of us are good drivers, would want a better car. So, and you would can move on to a dual-based pump where the venturi pump gives you such beautiful results and with minimal wound damage or corneal damage because you use lesser corneal energy. You use phaco energy lesser. Now, what would be an ideal machine? The ideal machine should be a jugaad. In India, we work on jugads. So I picked this, Gujarat and Rajasthan, everybody must have seen this. So it should be versatile. You should be able to use it as and when you want it. It should be user-friendly. You should be able to use it well. And it should be flexible. And this is most important. Kitna deti hai? That ad, I think you've got it right bang on with the photos. I haven't bought this, and I'm not going to buy it because we are flooded with phaco machines. So, but what I liked about this, the Nidec phaco machine was that they've managed to somehow get the combined platform in, and both the phaco and the vitrectomy solutions which they provide in a combined platform is the way to go. It is inevitable, in most of the posterior segment cases, cataract is inevitable. You would have diabetics with cataract, with progression of cataract. You would have patients who would require a combined surgery. You would need to look at, say, a patient with diabetic retinopathy, an ERM, macular hole, retinal detachment. These are patients in which you would not want to stage the procedure. At least now a lot of centers, including ours, we do combined surgeries. The advantages are a lot, but I'll first come to the disadvantages. How many of us have actually operated on a patient who's had a PPV done? The patient comes, sometimes the patients don't even tell you have got a soft, mature cataract, you don't know whether posterior capsule is there or not. Whether cataract in post-PPV would happen only when there's a posterior capsule attached. So, post-PPV sequential surgery has its disadvantages, and more importantly in today's time when you have the option of doing a combined surgery where you can actually give the result on the same sitting, and if the surgeon is capable to do it and if the machine provides you the platform, why not opt for it? The advantages, as I said, are many, and I won't go into that. I'll just briefly show you this video. And so essentially, in a combined surgery, the cataract would go on in the same manner as any, because the cataract is the primary surgery here, and the eye is virgin. The eye hasn't had any posterior segment surgery yet, so it has its advantages. The posterior segment surgery makes the eye soft. It makes it difficult to do the phaco. If there's silicone oil, you would have a very large positive upthrust. And so once you've done the cataract surgery, if you are planning on to moving on to a combined surgery, there are a few things which you should remember. There is no role for a single piece lens in a combined surgery. At least we don't. So it should be a 3-piece lens. There are multiple platforms available. You can then implant a 3-piece lens in the bag. Then move on at the same sitting. This is the same patient. Move on to doing the primary vitrectomy. And essentially, this was a macular hole patient. You move on to then doing the macular hole or the ILM peel. The advantages are profound. I don't know how many practices have moved on to a combined surgery. We have definitely moved on to it in all our patients, in which there's an indication, and we find it to be gratifying. We thank Nidec for supporting and bringing in this platform where they provide a combined platform which can give us consistent results. Thank you so much.
Thank you, Dr. Abhishek, for an excellent presentation. I think it really makes a lot of sense for having sequential surgeries, as you say, because in India also things are picking up and the patient's expectations have climbed a lot, and they do not want, for them time is money as it is everywhere. I think we now move on to Dr. Suresh Pandey, who doesn't need any introduction whatsoever. He's in Suvi Eye Hospital, Kota. He's a driving force who has been full of innovations and being the first to do so many things. And he would be speaking on my experience with the NIDEC preloaded IOL inject system. Dr. Suresh Pandey, please.
Thank you very much. Good afternoon, respected panelists and all the participants of this KLB Symposium. I'm just going to set up.
I think till the time you set it up, the most important thing which we as phacosurgeons we feel is that there has not been so far in all the with all the companies, like maybe I don't know whether it is the right platform to speak, Alcon, AMO, or for that matter the other ones who have a foolproof preloaded IOL inject system. They have had many, but no system had good results. I had the opportunity of using this preloaded system, and I was so convinced with it that it went beautifully. And the best thing about things was that it would go through 1.8 without any issue. Dr. Suresh, please. Are you ready?
Yes. Thank you, Dr. Rohit, for your comments about that. And welcome to this convention on the KLB on the advantage in phaco-dynamics and IOL implant. So I'll be quickly sharing my limited experience with the preloaded lenses. And while preparing an article from aphakic glasses to modern day IOLs for cataract refractive surgery today, I just reviewed the cataract surgery, and it was so exciting and interesting to watch that from the era of couching, there were so many advancement has undergone in the field of cataract surgery. The greatest invention in the field of intraocular implant is, of course, the invention of intraocular lens by Sir Harold Ridley, and another greatest invention in the field of cataract surgery is the phacoemulsification technique by Charles Kellman. And once these things came together, the invention of intraocular lenses and the phacoemulsification, there are so many new things are coming up. You can see there are so much advancement in the field of intraocular lenses and micro-incision surgery, micro-incision instruments. So while asking for my wish list for ophthalmology, I just wish that I could have a phaco machine combined with the laser and accommodating lens which can give the good accommodation. This is my wish list. I don't know whether it will be fulfilled or not. But let us talk about my experience about the NIDEC cataract technology. And I was a little late to use the NIDEC machine. And it was just by coincidence that one of the NIDEC guy, Mr. Kashi, he came to us when we were doing live surgery. He told that whether you would like to try our machine. So I was, I heard about this machine. I never had a chance to use this machine. But when I have chance to use this machine in a very hard cataract, I was pleasantly surprised that this machine, did extremely well, because I'm doing hard cataract with phaco technique since last 10 years. And to my surprise, this was one of the best machines which I ever used for my practice. So the NIDEC CV machine, this has very lot of interesting features. One of them is Auto Pulse System Plus, APS Plus. Another one is Variable Interval Strokes, VIS, and Burst Mode. So these two things are very unique feature which help NIDEC machine to deliver excellent results in terms of effective phaco time and emulsification of the hard cataract. So I'm just going to share with you this video. Video is not working, or so I'm just going to share with it's going to work. So this is the live surgery which we have done on 5th February with Kota Division Ophthalmological Society, and Dr. Vishal is also here, our secretary. So you can see this is one of the hard case, a very hard case, grade 5 cataract case, and we did vertical chop, and this was my first case using NIDEC machine. And how easily this was possible to emulsify this case so quickly. We of course did posterior capsule plaque peeling and implanted the preloaded lens. So let us have a quick poll. How many of you are using the preloaded lens in your practice regularly? Can you, Dr. Grover, what is your like which lens you prefer about the preloaded technology? Which is your most preferred lens? We have so many lenses available: the Alcon Ultracert, VVNX, iCert, and IDEC, SZI. Which is the most preferred brand in your practice?
I had largely been using the Hoya one
Okay.
amongst the pre-loaded ones.
Okay.
But I've used NIDEC recently and I really enjoyed it.
Okay, great. So we are all aware about that. The preloaded system has so many advantages. There is no need of loading the lens. It saves time, and there is no risk of contamination. There is an incidence of toxic anterior segment syndrome, TAS syndrome. So you can avoid any incidence of endophthalmitis or TAS syndrome because the lens is coming from manufacturer and directly going into the capsular bag. So this is the advantage, and of course, in high volume practice like Dr. Grover and Dr. Rohit Om Prakash have, it saves time because using preloaded lens save good time. So at present we have three most commonly used delivery system from Alcon, Acricert, Hoya, iCert, and NIDEC is there. So the advantage of the NIDEC system, I have very limited experience, but what I have seen is that this can be used through 2.2 millimeter incision, and the delivery, using this system is very easy and straightforward. There is not much learning curve. Just you have to inject the viscoelastic as very nicely illustrated in this photograph, and then fill up the with viscoelastic, and then just push it so that you see the lens is being folded. Once you push it, the injector, the lens will be, the leading haptic will fold like this, and you can see. And the most important thing is that the injector rotation is not required. It's not like a Hoya where you have to just screw it. You have to just directly push it. You can use with one hand. You can use with the hydro implantation technique. The other hand is free. So this is one of the advantage with this system. So I'm just going to quickly show you some of the videos where I used this lens. This is first case. This was my first case using the NIDEC preloaded system. I used NIDEC CV9000 machine to emulsify the cataract, and you can see this comes in a very nice packing. And the assistant opened the packing, and you can just peel it off. Once the packing is peeled off, the scrubbed assistant can take it, and then you can see inspect it for any problem. Then the first step is injection of OVD. Just you inject the viscoelastic from the hole, and once you inject the OVD, you can just push the plunger, and you see, you can watch the lens leading haptic is folded like this. So once the lens is folded, that is coming out in the capsular bag. You can directly deliver in the capsular bag, or you can use second instrument or dialer to position the haptic. And this has very unique features, and I'm going to show you just in a minute. This has very unique features, and this lens is wonderful lens, one of the very excellent lens in terms of the centration of the lens in the capsular bag, and the quality of the vision it provides in these cases. This is second case of the preloaded NIDEC IOL system. This case also, we used NIDEC phaco machine. This was a case of not very hard soft cataract, so we used the CV9000 system to emulsify the cataract, and then similarly you can see this is the packing, and you can peel it off, and then all, as I said, told before, that injection of the viscoelastic and then the pushing, you can use one hand. It does not require a screw mechanism, and the delivery, this system is it does not require very hard push also. It's very smooth. Sometimes once the temperature is low, and then you have to really push it very hard, and then lens come out like a missile. Sometimes it can damage the capsular bag also. You can see how beautifully this lens, that the leading haptic is folded on the optic. So, and here I'm just going to show you the injection of the lens in the capsular bag. You can directly implant the lens in the capsular bag, or take some help of the second instrument or dialer to position the trailing haptic into the capsular bag. So this is the case 3. This is the implantation of the NIDEC preloaded systems using hydro implantation technique. So I'm going to show you the use of hydro implantation technique here. So this is the other steps are the same. Only thing that I have not filled the capsular bag with the viscoelastic. I just use my irrigation port to provide continuous irrigation and use hydro implantation technique. This technique can be helpful in some cases of toric lensage, where removal of the viscoelastic is very important, because if you leave viscoelastic in the bag, then it can be rotation of the lens. There can be rotation of the lens. So here, this is my irrigation port, and the lens is going inside the capsular bag using hydro implantation technique. So, this is, I have limited experience, but in my experience, this is one of the very interesting lens for me, and it center well in the capsular bag, and it provides excellent vision to the patient. So the now question comes, how this system is different from the existing system. One point Dr. Grover very correctly pointed out that with the Hoya system, you have to use the screw mechanism. And Dr. Rohit, you have used a lot of ultrasert lenses. How do you find this lens is different from the ultrasert what you have used?
I think the best part about this lens is that the delivery is very smooth.
Okay.
There is with the original one, which was Acrisert, that was that was fully problematic.
Okay.
Number one. Number two, I think with 2.2 there is no struggle in this injection system. That is another part.
That's very correct.
And another important thing which I feel is that when you push it in and when you press it, it goes right into the bag.
Okay, that's very good point. Yes.
And then the loop system gives a good centering, which I think in long term should help.
Yes.
Baki, the time alone will say how things. The NIDEC people, they are known for quality.
Yes.
And it is, I suppose, FDA. It has FDA NIDEC approval for Japan for last how many years, if I'm asked? For many years.
Yeah.
So
but in India it came late, but I think they are using Japan for
and
many
the
years.
spherical aberration is 0.14.
Mm-hmm.
So if you want to have a good array of IOLs with 0.27, 0.2, 0.14, then this really fits into your system of all these things.
Yeah, that's very good point, Dr. Rohit, you have mentioned, because this provides very stable refractive results because of anchor wing haptic configuration of this lens, because if you compare the other lenses, this is very good.
This would decrease the alteration in position with the contraction of the bag in the long term. This design, particularly this 90-degree angle, this is going to make a difference.
I think this reminds me of the Simcoe lens. You remember that?
Yes, Simcoe lens.
Yeah, the classical C type.
That's very good point. Because with the lens epithelial cell, there is always some amount of capsular bag contraction. So this design, is provide resistance for that capsular bag contraction and that forces which causes capsular bag contraction. And if you see that this measurement from here to here is 9.5 millimeter, and other lenses they have measurements range from 8 to 9.2 millimeter. So this also provide very stable refractive results because it covers the wide area of the capsular bag, capsular equator. So at present, we have so many systems which are available in the market. I have used all of them, and I found that this preloaded system is excellent and provides excellent results because of so many design features of you can inject through 2.2 millimeter incision, and also there is no need of the screwing it. You can directly implant in the capsular bag, and 360-degree square edge provides minimal PCO. There is a very less chances of PCO. So with this, I want to conclude my talk about my initial experience with the NIDEC preloaded lens. Thank you so much.
Thank you, Dr. Suresh. Now we move on to Dr. A.K. Grover, who is from Vision Eye Care, New Delhi. He would be speaking on enhancing outcomes with improved fluidics with lens design.
Thank you, Dr. Rohit. It's wonderful to be a part of this symposium where we are discussing some of the basic things which we often don't really discuss in these conferences. That is the basics of the phaco-dynamics, the fluidics, which the advances that are going to make a difference to how we deal with our patients. So the title of my talk is Enhancing Outcomes with Improved Phaco-dynamics and Fluidics. Now, as we know, the better outcomes imply that we deliver a pristine, clear cornea on day one to our patients, which is now more or less a necessity. There is so much patient expectation, as Dr. Suresh was saying, or as Dr. Abhishek was saying, that patient wakes up from the table, gets up from the table and says, where is my vision? I don't see. So, and next day at least he would expect to have good vision. So this wow factor can only be delivered if we have a pristine, clear cornea on the first day. It requires measures in the preoperative, intraoperative, and postoperative periods, but the one that we control most during our handling is the intraoperative measures, which can make a difference. And that's where the phaco-emulsification machine is very important. We need to understand the machine, particularly its fluid dynamics and the power modulations, which have made a difference to the amount of energy that we use and to deliver the crystal clear corneas on the next day. Of course, there are other important measures in our surgical technique which we need to look at. For modifying our phaco-emulsification technique in the best interest of the patient, we need to reduce surgical time. We need to use phaco power away from the endothelium and have minimum possible chatter and movement and have a high followability. And how do we get that? How do we reduce the energy? By using a high vacuum phaco and using power modulations which make it possible for us. So let's see how the improved designs of IOL, of the phaco-emulsification machines, are helping us to do that. And I've had the opportunity to use the CV9000R system from NIDEC, and this experience has been a very pleasant one. It gave me such good followability at such stable chambers that I really enjoyed working on this machine. And this ability, the vacuum, that high vacuum that this machine provides, is the function of the improved peristaltic pumps that they've used. And the result is that you have a very high vacuum rise time, where they've designed it so that you reach to 200 within no time, and then 200 to 400, the rise time is much faster than the earlier machines and is virtually the same. In fact, it is the same as any other machine available, including Sovereign or Infinity or any others. But the most important thing that I enjoyed most was the power modulations in the system, which have enhanced the efficiency of lens fragmentation, improved followability, improved chamber stability. The machine, of course, has the hyperpulse mode, which is up to 100 pulses per minute. It has incremental mode. It has what it calls the APS plus system, and this is something that I'm going to elaborate about. Burst system we are all aware of, but there is a VIS system as well, which I'll briefly talk about. We all know the pulse mode, and we know that here you have pulses adjustable up to 100 pulses per second, which gives us the optimal on time and optimal duty time, which gives us the least possible energy consumption. The incremental mode has an advantage in the sense that it fixes the on time, but the frequency can be changed by your foot pedal. So when you start, if you have 50 pulses in the beginning and you are pressing on your foot pedal, it gradually becomes 100, and your on time remaining the same, your duty cycle then changes from 40% to 80% as you move your pedal down, which allows you to do the phaco-emulsification much more efficiently. When you want more energy, you get a greater duty cycle. But the APS Plus mode has brought in some innovations which I thought somebody should have thought of earlier. I mean, those are things which really have done some wonders, where the pulse frequency is being adjusted after the tip occlusion, and after the occlusion is released, the ultrasound and aspiration are controlled in a way that you get no risk of surge and therefore of causing a damage to the posterior capsule. So let's look at the advantages or the technique that is being offered. So APS Plus system is essentially giving you that when the phaco tip is occluded, there is an automatic increase in the pulse rate and therefore pulse duty, which provides a very good control for phacoemulsification. So when you need more energy after occlusion, that is when it provides more energy. Also, after the, as I said, when the occlusion breaks, immediately you have the aspiration stop and you have the phaco stopped for a time which can be programmed. So it can be about 2 seconds, and that is a great mechanism for preventing surge and preventing damage to the posterior capsule. So here you see that this mechanism is functioning. So this is a piece approaching, and so once the occlusion takes place, the frequency changes and allows greater energy. Now with the occlusion, you can see how much more energy it is delivering to easily eat up the fragment. And then it becomes silent. No aspiration, no power for a duration of about 2 seconds or whatever you can program according to your choice. So this has made the followability beautiful. So we are doing this case, and this is virtually real time, virtually no editing. So we have done the initial trenching, just a couple of passes or 3 passes are usually enough. And then you can divide the lens into 2 fragments. And then we are doing our chopping. We have a very good hold. And what you'll observe is that the fragments are eaten up so beautifully. As soon as the occlusion takes place, you are easily able to take away the fragment. So same here as the occlusion takes place. But when the occlusion breaks, there is that total stability of the chamber because the aspiration has stopped for a given duration of time. So we're doing the same on the opposite side and taking away all the fragments, and it makes your things faster and more efficient. We look at a case which is with femtolaser assisted cataract surgery. So you have the rexus available to you and you have the fragments. So once you've divided into the fragments which have already been done by the laser and the lens has also been softened, the emulsification is very much easy, but what you find is that the stability, repeated breaks of occlusion are not making us worried about any surge whatsoever. It's the stability and the efficiency and the improved followability which is making life easy for us. So this thought about the stopping of energy for a given period of time as well as the stopping of the pump for that duration has made it very, very safe, allowing you to use much higher vacuum levels. So now what about the VIS mechanism? So variable interval and strokes. Here you have conventional pulses, but there are ultra short duration pulses which are superimposed on that and separately as well. You can have all that customized. Now those ultra short pulses are ensuring that you get that energy for either impaling or for eating up the fragments. So this is the main pulse and that was the sub pulse. But it is not pushing away the fragments. So your followability has become very nice. So this is another option availability. So you look at the main pulses here and look at the sub pulses. These are much smaller pulses, smaller pulses given out at definite intervals here, but the two can be combined in various functions like here that you see. Now you have a combination of main and sub pulses and you have sub pulses here. So these increase the efficiency of emulsification and maintain your followability. So here we are doing the trenching, and we are using the VIS system here. Again, division into fragments by chopping off the halves, and then, as you notice, once we start eating these fragments, the advantage comes in immediately. And you can notice the improved followability and stability of the chamber. So this fluid dynamics has really made us work more efficiently with lesser energy consumption and making the procedure simpler for us. So that is what is making this system. And of course, there are other advantages that this machine is offering us. It is offering freedom from cassettes, from disposable cassettes, so which is one major advance that we have. And all the parameters are very easily programmable, including you can feed in 19 gauge, 20 gauge, or 21 gauge. And at the end of the surgery, you get all your data for the given case, which is nice. And for multifunctional foot switch, where everything is programmable, everything is adjustable from the foot switch, makes it very easy to use. So to summarize the strengths of the CV9000, it gives a performance which is excellent, and its cost is very cost effective, matching the more costly machines, a very reliable vacuum, and a quick rise time, very trustworthy anterior chamber stability. This is the strongest point. I did not notice any microsurges at all at whatever parameters, and the ultrasound modulations. So of course, these are the features, standard features, surgeon-oriented and operator-oriented interfaces which are helpful to you, but these two form the most important features of this machine. Thank you all for your kind attention. So how's your experience been with the machine?
Yeah. Before I answer, I would like to ask one question. You have without the cassettes also? Both, yeah. This point should also be, I think we should, because for Indian conditions, for surgeons...
That's vital.
Yeah.
Yeah. So the cost of cassettes can sometimes be prohibitive because one may not have 10 surgeries every day. So and the cost becomes very prohibitive if you have just a couple of cases to do on some day.
Yeah, absolutely. And I did find the fluidics good. The chamber stability, as you mentioned, was excellent. The post-occlusion surge, even in minor surge in grade 4, grade 5 cataracts, was admirable for that matter. Yeah.
Yeah, please.
How do you compare this machine from the signature or more intuitive machine?
In fact, I was using them interchangeably, and I was as comfortable with this machine as with any other. I use all 4 machines. In fact, I operated 3 different centers, and there are 4 different machines that I'm using. With this machine, I have absolutely no reservation. I did the hardest cases, the white ones and the brown ones, and had no reservations on any case. Thank you very much.
I think we move on to the last talk, which is by Dr. Adel Sampson. He would be speaking on his experience with NIDEC FECO CV9000 and IOL-SZ1.
Okay. Good afternoon. Thank you, panel. Thank you, NIDEC and Mr. Diwakar for having me here. I'd like to talk about my experience with the CV9000. I'd like you to see it for its safety, efficiency, and efficacy. Let's talk about safety. Safety is the freedom from occurrence or risk of danger or loss. In our case, vitreous loss. We don't want that. We want to be able to have a stable chamber and prevent surge. Here's an example of what we don't want to happen. You may notice that after every eating of the cataract, you will notice some depression of the cornea, which is surge. There, emulsifying cataract, and after post-occlusion, boom, you have a hole. We don't want that. We never want that. So what did NIDEC do to address this particular problem? It actually redefined the cassette structure and added the irrigation assist bottle. It has something to do with surge reduction. Well, actually, that's the only thing that they're actually concerned about. Here's equilibrium. Here's the bottle, and this is at normal equilibrium. Here, you will see that there's normal flow because there's no occlusion of the tip. So we have normal flow from the bottle to the cassette, and there's a layer of air here that has a potential to push fluid when there is occlusion. So this is equilibrium, nothing happens. There's strict direct flow. But once the tip is occluded by a nucleus, there's no way for the fluid to go out. Therefore, it presses on the fluid here inside the irrigation assist bottle and compresses air. Now, this air has the potential to push this fluid out once there is post-occlusion, once there's occlusion break. Since we have occlusion break here, what happens is air here pushes the fluid out into the chamber, preventing surge. That's the design of the irrigation assist bottle. Let's talk about efficiency. We want to achieve maximum productivity with minimum wasted time, effort, and expense. Here we're talking about, in the machine, we're talking about ultrasound. Let's talk about heat and chatter. These are traditional hyperpulse modes. There's always this chunk of cataract always thrown every now and then. So if that accumulates, you have wasted time, wasted ultrasound energy, and producing much, much more heat than necessary. That's causing a lot of injury to the endothelial cells. So the highlight or the flagship of the CV9000 is the APS Plus. It was explained earlier by Dr. Grover that upon occlusion, everything stops. And also upon occlusion, there is an enhanced, let me show this. I think it was shown earlier anyway, but just to let you know, at about this time, we want the cataract at the tip, where all the action is. And once there's occlusion, there's increased power of ultrasound, and after occlusion, everything stops. There's no vacuum, there's no ultrasound, there's no aspiration. So that's how we want it. We want it safe. We want it reproducible. We want to be able to do it over and over again. So that saves a lot of risk for engulfing the posterior capsule. So here, ultrasound, stop, machine stops, pump stops after post-occlusion. Now this small ultrasound power just brings the cataract at the tip and keeps it there. Once there is occlusion, ultrasound goes up and emulsifies it and then stops. You can program the amount of time that's mine is 0.5. Okay, here's probably the first time I use this. Watch what happens and observe this area. When it turns orange, that's when the machine stops. That's post-occlusion. Okay, so I'm actually doing a chop. Notice that? So you're assured that there is no inadvertent cataract as a surge. No? It minimizes surge because the machine stops. on top of the irrigation assist bottle. Therefore, you have a very stable chamber no matter how high your vacuum or your aspiration is. I've tried this, my aspiration is 42. I've tried it to the limits of 60, and nothing happens. Post-occlusion surge is nil. So here I'm emulsifying cataract. And the nice thing is, the cataract just stays at the tip. It doesn't cause any chatter. So it's just there at the tip. Notice that. When you're done, easy as pie. You can actually just step on the foot pedal, floor it, and the machine does everything. You can actually have chai while doing this. Okay, so in terms of efficiency, you want to have intelligent use of ultrasound to decrease surgical and ultrasound time, decrease ultrasound energy expenditure. In terms of safety, we reduce collateral damages to the surrounding structures and tissues. Now let's talk about efficacy. But before we can talk about efficacy, you want to be able to define reproducibility. You want to be able to duplicate every single thing, every single step that we do. Therefore, when we do that, we have the ability to produce a desired and intended result, which is efficacy. I did this study about a little more than 3 years ago, almost 4 years ago, on using the NIDEC CV9000. And I did a comparison of grade 3 and grade 4 cataracts on 1,046 eyes and 1,024 eyes, respectively. And I found that my mean surgical time was about 6 minutes with effective phaco times of 36 seconds on grade 3 cataracts, and on grade 4 cataracts, it's 2.31 seconds. Now, comparing the two, there's actually no statistically significant difference. Meaning, whether it's grade 3 or grade 4, you get the same effect from this machine. Actually, even my phaco times are shorter on the grade 4 cataracts. That's a proof of efficiency of this machine. I was even surprised when I did this study myself. So there you go. It's just proof. So here, I'd like you to, just a review. For stability, for safety, we think about chamber stability. For efficiency, we think about ultrasound efficiency. And for efficacy, we think about reproducibility. Now, that's my segue to my next topic of photography. What's the most important thing in photography? It's the lens. And for sharp lenses, I use a Leica. I just tried the Leica yesterday. I'm evaluating it for the launch in the Philippines on Tuesday. So I'm launching it. I'm evaluating the lens, and I shot the Albert Hall last night, 2 nights ago when I got here. I went to this small village. It's a very small, poor village. And I shot these people. They were so willing to be shot. Same as this, same village. Right? Same village too. And I went to Pushkar yesterday morning. And I shot this. This was sunset.
Brilliant.
Thank you. Thank you. This was sunset. Sunrise was also just as good. So Pushkar for me is one of the better landscapes around, actually, probably in the world. But there's a lot more. I love India. I love coming here just to shoot. Anyway, since the lens is important for me to deliver sharp images in my photos, so is the lens in the eye. I'm here to talk about the NIDEC Atkis SZ1, as everybody else has shared, and I'd like to share my experience as well. I tried this lens about 2 years ago. It wasn't FDA approved yet in the Philippines, but I got to try it just to be able to try it. Nidec brought me some lenses, and I used it, and it had wow features for me. It had intraoperative wow features and post-operative wow features. As mentioned earlier by Dr. Suresh, it's highly predictable in terms of its injection system. It's oriented actually vertically instead of horizontally. I don't know if you noticed that. It goes in vertically. It's oriented even vertically and goes in and torques, shifts to a horizontal plane. It goes through a true 2.2, so there's no need for wound assisted, which is more stable, and you're actually more secure that it's going through the chamber. Through the bag. It has a very gentle unfolding, and yet it's swift. So here's that video. That was shown. So it goes through this very tiny 2.2 millimeter incision, and it just unfolds readily. It's oriented vertically and then shifts to a horizontal orientation. The nice thing is it has very good centration. Why? Simply because of its long haptics. It's 9.5 shoulder-to-shoulder length versus all of these, which are just shorter. So it gives us better capsular support, a greater contact area on the periphery, which actually centers it well. Okay, for post-operative wow features, it's so easy to predict. I've been using just the simple SRKT formula, and it gives me the exact results I want on the money. There's absolutely no glare. I have not seen a patient who actually complained of glare for this monofocal IOL. And why is that? The finish of most intraocular lenses on the sides, on the walls, are smooth. This one is, you may liken it to a sandblasted finish. It's manufactured because of a slower cutting machine. So the slow cutting machine gives us this rough finish. So it reflects less light or diffuses light and doesn't produce any glare. So if you compare the ATKIS with the others, all of AMO, Hoya, Alcon has a lot of glare simply because their edges are smooth. And the ATKIS is not. So again, there's almost no cyanopsia, no blue vision, because they reduced the blue blocking wavelength by half. Therefore, it gives some blue and removes the violet. So there's no cyanopsia, actually. And in all of Asia, it's been reported that there's only about 3% PCO. That might be bad business for us because we don't get the YAG match. But it's nice to know that NIDEC has the best interest of the patient. Okay, so with that, I'd like to say thank you for having me here. That's me sharing. And with the lens, I was able to, you can see me through that small window of the Albert Hall. Thank you very much.
Thank you. Your slides were as artistic as your photographs. So
Thank
that
you,
was
sir.
wonderful and
Thank
a
you,
very
sir.
nice presentation.
Thank you, Mr. Grover.
With that, I would like to thank all of you, and would hand over to.
Thank you, sir. And I think it was a wonderful lunchtime symposium on something, talking on NITEC. They've been there in an ophthalmic scenario for such a long time. And wonderful systems. And these new lenses which has come would be, a feature for all of us to use in future. If this lens has no peripheral images, nothing better than, and 3% PCO rate is one of the minimums possible with any intraocular lenses. So looking forward to using these lenses if they also give a little bit of lenses to be used in the RP center also. And one feature which we appreciate is a very exciting phaco machine is, post-occlusion surge. And that's a wonderful thinking and application.
That made me wonder why people had not done it earlier.
Yeah, I think that's a very good concept. And if that happens, this machine should be for all of us. And what he showed, in Philippines, you do have a lot of hard cataracts. But the 8.8 CD was great in grade 4 cataract. If that happens with any machine, that's a machine to be used. I hope that we'll all have access to NIDEC systems. The people sitting here, they all have a knowledge of this. And thank you for all. Dr. Rohit, you want to say a few words?
Yeah, I think we're already running late because the next session is we are late by 5-7 minutes, so I think we should finish it off. Yeah.
Welcome, Dr. Kasturi. Take over.
Who is the next speaker? Dr. Suresh is there, and
Dr. Grover.
Dr. Grover himself.
Yeah.
Yeah. Next is
Dr.
Adil. We'll just take one more minute. Okay. Next for Dr. Rohit.
No. Dr. Amre, Dr. Dagar.
अच्छा डागर तो है नहीं यहाँ पर. Dr. Grover sir, he deserves the biggest one. Yes, truly sir. Dr. Rohit. Okay, हम तीनों आ जाते हैं साथ में.